Good evening, friends. Sorry for making you wait for 2-3 minutes. We have some issues with the internet, the YouTube. So we have two important cases. One is going to be presented by Dr. Karthikeyan from Coimbatore Medical College, kindly contributed by Professor Srinivasan sir. And we are able to have another presentation. In fact, this candidate has been kindly recommended by Professor Vikram Kate sir. Almost few weeks before exams and other commitments, the case should not come in. So we are glad to have you on board. Dr. Lakshmi Satish will be presenting on left iliac fossa-mass. So we have three invited faculty. Professor Vikram Kate himself from JIPMER. Thank you, sir, for joining us. And we have Professor Birappa sir, Professor and Head of the Department of Surgical Gastroenterology from Nizam's Institute. Thank you, sir, for joining us.
Thank you, sir.
We have Professor Shilpa Rao, ma'am. She has some challenges in joining. I'm trying to help her out. Madam is she is a professor and head of the unit of general surgery from KEM Hospital and Seth GS Medical College, Mumbai. So these are and our regular faculty, Professor Srinivasan sir, Karnakaran sir, and others are joining us. We could see Dr. Hemant Natiyal from Jolly Grant have joined this.
Evening. Good evening, sir. Good evening.
Good evening, sir. So we'll have the first candidate from JIPMER, Dr. Lakshmi Satish. Dr. Lakshmi, are you with us? Dr. Lakshmi, do you have any challenges, Dr. Lakshmi?
Yes, sir. The presentation in PPT mode, PDF mode. Can I have a few minutes, sir. 1 second.
We are unable to see you, Kanak. Do you have any challenges? Yeah, we are able to see you now. Yes.
Yes, sir. Am I audible, sir?
Yes, very well audible.
Yeah, we are able to see your.
Are my slides visible?
We are able to see your slide.
Okay.
Slides are yet to come in, ma. Yeah, we are able to see your slides, Kana.
Yes, sir. May I start, sir?
Please, ma, please introduce yourself, your unit chief, your head of the department, and start your talk.
Yes, sir. Am I audible, sir?
Perfectly audible, ma.
Okay, sir. Good evening, everyone. I'm Dr. Lakshmi. I'm third year JR in JIPMER, General is Dr. Am I audible, sir?
You are audible, ma. You carry on. You are audible. If there's anything, we will tell you. Don't worry.
Okay.
You're
Okay.
You are audible.
Sir. Okay, sir.
There is some disturbance. Somebody is joining. They'll mute themselves. You proceed. All the best.
Okay, sir. Myself, Dr. Lakshmi. I'm third year JR from JIPMER. My head of the department is Dr. Kadambari. I would like to use this opportunity to thank Dr. Kanagavel and this forum for giving me this opportunity. Can I proceed with my presentation, sir? Am I visible? And
yes, you are visible. Your slides are visible. Please go to this.
Okay, sir. I'll be presenting a case of a 39-year-old male, tailor by occupation, hailing from Pondicherry, who presented with complaints of left lower abdominal pain since 1 month. He was asymptomatic until 1 month back when he started developing abdominal pain in the left lower abdomen, which was of dull aching type, continuous throughout the day, not associated with bowel movements, not completely relieved with analgesics, and not radiating elsewhere. He had no history of any alternating bowel habits, bleeding per rectum. He had no history of fever, loss of weight, or right? He had no history of tuberculosis, history of hematuria or pain in the left flank, No history of easy fatiguity, breathlessness on exertion. No history of any obstipation, vomiting, or abdominal distension. He's a known diabetic on regular medical management. History of any similar abdominal pain or any such complaints in the past. Hasn't had any abdominal surgeries or hospitalizations in the past. He has no history of any cancers in the family, mostly colon, breast, and uterus. Personal history, he takes a mixed diet. He has a normal bowel and bladder habit. He's not habituated to alcohol or allergies. Treatment history, he took over-the-counter analgesics for the abdominal pain. He was not evaluated for the complaints elsewhere. Summary, a gentleman, 39 years of age, with left lower abdominal pain, with no other symptoms such as alternating bowel habits, fever, past history of tuberculosis, or any significant family history.
Dr. Lakshmi, good evening.
Good evening, sir.
Yeah, you said you particularly asked there is no history of, can you please go back to the previous slide? Specifically, you mentioned there is no family history of colon, breast, and uterus. He's a young guy, 39-year young guy, who has just has a pain in the abdomen.
Yes, sir.
So why specifically you asked all that kind of an history when he has no altered bowel habits? He has no other bleeding per rectum, which doesn't suggest of no symptoms suggestive of any colonic pathology. I just would like to know, why did you ask for those history? Specifically, you mentioned is a male, and you mentioned there's no history of colonic cancer, breast cancer, and uterine cancer.
Yes, sir. I was just ruling out everything, sir, because with just the symptom of abdominal pain and no history suggesting any benign or malignant pathology as such, I wanted to rule out all of it. If it's a malignancy, then I wanted to rule out if there is any family history, because he is particularly a young male. So if he has any family history, then it's a pointer towards thinking towards malignancy in a young male with such short history.
I would rather ask him urinary symptoms, any history of, colic pain, burning micturition, that kind of history. I'd be interested at this stage than asking for all these kinds of
complaints. Yeah. Yes, sir. The only urinary complaints I asked for is hematuria.
So there's no history of any urinary symptoms.
No, sir, no.
Okay. And dull aching, constant pain, which is not relieved by the drugs. That's what you said.
Yes, sir.
So
Not complete.
What could be the reason, Dr. Lakshmi?
Dull aching, continuous kind of pain rules out any ureteric colic or any colicky pain or obstructive pain. Dull aching pain would be due to the distended bowel, distended colon, or any stretching the peritoneum. So, irritating the peritoneum or the stretching of the bowel. That could be causing this dull aching, continuous pain.
What could be the main reason of dull aching pain in the abdomen?
Distended viscera.
Distended viscera will have dull aching pain. Why the viscera should? Distended viscera means, you mean liver, solid organs?
No, sir, hollow viscous organ, distended hollow viscous organ.
Why the hollow viscous organ will distend? If there must be some proximal obstruction to say it's distended.
Yes, sir.
When there is no proximal distal obstruction, why it will distend? What could be the reason? Forget about all the diagnosis. He said abdominal dull aching time of pain in the abdomen. So what are the causes of dull aching pain?
Dull aching pain could be due to
I'll say it's an hepatomegaly or splenomegaly. Can it cause dull aching pain?
yes, sir. If it's constantly stretching on the liver capsule, it could cause dull aching pain.
So splenic enlargement can cause dull aching pain. I'm just asking you.
Lakshmi, this is a visceral pain, or is it a somatic pain? Autonomic. Is it autonomic or is it somatic? This kind of pain. You know the difference between somatic
Yes,
pain
sir,
and
this is
autonomic
somatic-
pain.
This is somatic pain, sir.
So what is the difference between somatic pain and autonomic pain?
Somatic pain is because pathology in a particular viscera that could cause stretch of the peritoneum or the.
I'm not asking you what is the cause. Tell me the difference between somatic pain and autonomic pain. What's the difference between the two? You said this is a dull aching pain. Is
Yes.
is somatic pain dull aching, or is it sharp and localized?
Dull aching would be more of a somatic kind of pain. Somatic kind of pain would be more.
No,
Not
it's the other way.
somatic pain and your visceral pain.
It is
Only
different.
different.
Look,
Skeletal pain or it's a visceral autonomic pain.
like in appendicitis, initially what do you have? You have an
Periam-
autonomic pain.
Yes,
When it
sir.
touches the peritoneum, you get somatic pain. So initially it's dull and generalized. Then it becomes sharp and localized.
Yes, sir.
So
Yes.
this
Lakshmi, can I ask a question?
Yes.
Yeah.
Ye-
So,
yes, ma'am.
yeah. So basically pain is one of the most common symptom that a patient with an abdominal, etiology comes to us with.
Yes,
So
sir.
can you just enumerate the different kinds of pain and what they mean? I think everybody's asking you the same thing. So what kind of pain signifies what kind of pathology?
Okay, ma'am. A sharp pain localized to a particular area will be a somatic pain. A dull pain will be more like an autonomic kind of pain. A dull pain,
No.
diffuse dull pain.
No, but what kind? What does it mean when you're saying it's dull? What is the actual reasoning behind it?
When you can get a colicky
That
pain.
it's-
Colicky
it's-
pain is also a somatic, visceral pain only.
Localized disease, sir. Like a colicky pain will point you towards the origin of the pain, like ureteric colic, localized
Not
pain.
point to it. It is a loin to groin. Anywhere it can come. Do not point to that.
So, so colicky pain is more of a smooth muscle, this thing. But so if you're talking about a dull aching pain, which is typically what a patient presents. So a patient comes with dull aching pain, what does it really indicate to you?
A hollow viscous smooth muscle, hollow viscous pain. Ma'am.
So it's some kind of venous inflammation. It may not be arterial, because in arterial pain, you will get what kind? In the
Throbbing kind.
abdomen. In abdomen, you may not get throbbing. Okay, you could get throbbing pain, but what is the other kind of pain in ischemic bowel or disease? You get the patient presents with a very classical kind of pain.
Postprandial pain. Ma'am.
No, so it's like an angina.
Angina, postprandial angina.
Right? So it's a very classical pain. This thing, it is a very severe kind of somatic pain which will happen in this thing. What other kinds can happen? Which other kinds of pain can happen?
What other kinds in the sense?
Radiating pain, referred pains.
Yes, ma'am. Radiating pain, referred pain, shifting, migratory pain.
If a pain is radiating to the back,
Yes.
right? What does it indicate?
Radiating to the back means
if the patient comes with history of pain in the abdomen or a swelling in the abdomen or a lump in the abdomen, and then he says or she says that the pain has then started radiating to the back and it has become a continuous kind of boring pain, what does that indicate?
I would suspect the pancreatic pathology there, ma'am, with the infiltration in the retroperitoneum or a celiac places infiltration.
Yes. Okay. Please continue. Stop.
This patient has, what is the GA tract? Any symptoms? Yes, no appetite is good, no vomiting, bowel habits
Yes.
normal.
Yes, sir.
Except you are expecting a frank bleeding. This patient has a frank hematochezia.
No, sir. I was expecting. No, I was not. I
No,
asked
it
his
is what you have. You have a hematochezia or melena.
hematochezia, sir. Lower abdominal bleeding. Lower
Is
GI
it
bleeding.
is it mandatory lower abdominal pain has to be melena? I mean hematochezia.
No, no, sir. No,
Can
sir.
you get melena in a lower abdomen pathology? So these are
Yes,
lower
sir.
pathology. When the transit time is more, it will go for
Yes.
oxidative reduction, and you will get an altered blood. When it has to travel from right side to all the way to the left side, it most of the time it goes for a oxidation. Oxidation of the heme will route the hematin.
Yes.
Why do you look for the black spots across the body? You have said there is no black spots in the body. Is there anything you have in the mind?
Sorry, sir. I didn't get you.
In the history you have mentioned, there is no black spots all over the body.
Black. I have not mentioned, sir.
No, she has not mentioned that.
Yes.
She has not mentioned. I don't think you have mentioned.
Okay, then go ahead. So,
Okay. You also mentioned that there's no history of tuberculosis. So what history did you elicit? How do you say that he did not have any history of tuberculosis?
Sir, I asked for a history of pulmonary tuberculosis or of any non-specific symptoms like weight loss, loss of appetite, easy fatigability, etc., and of pulmonary tuberculosis in the past.
Lakshmi, this is a left iliac fossa pain, right? Mass. It's a left iliac fossa mass.
Yes,
So,
sir.
what kind of tubercular lesions will actually cause a left iliac fossa mass? I mean, what was your logic
Madam,
in asking?
we have not come to the examination point. It's been discussed. Only history point.
Okay.
We just would like to know what history she elicited to confirm.
Yeah, even on history, if the patient has
Yeah.
come with a lump, then what is she looking at if she's asking for tuberculosis?
Yeah.
Mesenteric tuberculosis, mostly on the right side, it's ulcerative, ma'am. And on the right side, ileocecal, ulcerative. On the left side,
No,
tuberculosis.
Lakshmi, I'm not asking you the different presentations of tuberculosis. I'm asking you how did you want to correlate the history of tuberculosis to a left iliac fossa lump? Or you just asked tuberculosis as part and parcel of your history?
No, ma'am. No, I just asked to rule out if even though left-sided tuberculosis is not common, I wanted to rule it out. That's all, not as.
You should specifically ask for, evening rise of temperature. Not exactly in this patient, but if you want to rule out any history of tuberculosis in the abdomen, history of loose motions, so low grade fever, evening rise of temperature, past history of pulmonary tuberculosis, and if there is any distance in the abdomen, indicates an ascites.
So Lakshmi, when you're talking about tuberculosis in the lower abdomen, it is seen more commonly, and especially on the left side, it may be seen in women, okay, where they have involvement of the TO junction and things like that. Rarely would a left-sided tuberculosis cause, rarely would a tuberculosis cause a left-sided mass in a male patient.
Okay.
Yeah, go on.
Okay, what do you think based on history, Dr. Lakshmi? He has only history of pain in the abdomen in a young guy. No past history of all those things. And so what do you think clinically he has?
Yes, sir. Young male with a short history with lower abdominal dull aching pain, probably pathology arising from the colon because there is no pointer as to ureteric involvement or anything. So probably a pathology in the colon. Could be, I can't make out really if it's benign or malignant also, sir. He has no constitutional symptoms or symptoms of benign pathology like diverticulosis. Being it a short history, I can think of a colonic pathology, probably a new colonic pathology, sir. I'm not.
What are the negative points, ma? You tell me. I say it's not a colonic pathology.
A colonic pathology will not, if it's a short history and there are no other pointers like bleeding per rectum or of any alternating bowel habits, just presenting with left-sided lower abdominal pain.
What made it colonic pathology? You're keeping, I mean, just because we had announced that this is probably a case of colonic pathology, that's why sticking on to the colonic pathology. When what made you to think colonic pathology? He has no history of constipation. He has no history of passing blood per rectum. He has no history of passing loose motions. Nothing, no altered bowel habits and nothing. So why did it say it's a colonic pathology? If this patient had an altered bowel habits, I can think of a colonic pathology. Or if he had a constipation, I can think of. Or if he had an obstipation or vomiting, and some GI symptoms at least, I can think of colonic pathology. He doesn't have anything.
Yes, sir.
Lakshmi,
Yes.
does the patient have any history of worm infestation or anything? Have you taken that history? Because in a young patient with just pain abdomen, with nothing else, I mean, it could just be some kind of a colic, it could be renal crystals or renal colic or something.
Yes.
Any worm infestation?
Worm infestation, I did not ask for, sir.
That could be one.
The undescended testis. Have you asked the history?
Sir?
Have you asked the history for undescended testis?
No, sir, I looked for it in examination, but I did not ask.
The history only we are saying. History only we are.
I have not asked for it.
You are sticking on to colonic mass. So that is why you have forgotten to ask all other reasons what are the mass could have been there in the left iliac fossa.
Okay.
The history should be the brain book.
Yeah.
You should take almost all the history related to that. What are the possibilities there? Especially in this case with the mass level, you are saying a swelling, but there is no symptoms pertaining to the colon. Then you should have the history sitting for all other reasons for that.
I mean, doctor, for pain abdomen without anything else, you have to route lymph nodes, lymphadenitis, you'll have to some kind of infection, some kind of obstruction, some kind of foreign body, something. I mean, we are not just. I mean, it's really enigmatic.
It could be anything, just pain abdomen in the lower abdomen on the left side. It could be in a lymph nodal mass, so that's causing a pain. It could be anything.
Can we go for examination? Maybe throw some light.
Yes. Go ahead, Lakshmi.
Yes, sir. Examination was done in a well-lit room after taking verbal consent in the presence of a male chaperone. He was comfortable at rest, afebrile, well hydrated, well built and nourished, with a body mass index of 22. With a good performance status, he had no pallor, icterus, pedal edema, or lymphadenopathy. His blood pressure was 110/70 on the right arm in supine position. His pulse rate was 77 beats per minute, regular. Examination of abdomen. On inspection, the abdomen had a flat contour, flanks were not full. All quadrants were moving equally with respiration. Umbilicus was normal, central in position, inverted with no fullness or nodules. Skin over the abdomen was normal with no scars or sinuses. There was no fullness, visible mass or peristalsis in the abdomen. Inguinal region was normal, no swelling or fullness, no cough impulse. External genitalia was normal. Spine, no deformity was noted. Renal angle, no fullness was seen. No supraclavicular fullness was seen. On palpation, there was no area of localized warmth or tenderness. A lump was palpable in the left iliac fossa, which was hard, non-tender, nodular, mobile, more in the transverse direction and restricted mobility in the vertical direction, measuring around 7x5 centimeters with well-defined margins. Liver and spleen were not palpable. Inguinal region, there was no swelling or cough impulse. External genitalia was normal. Bilateral testis was palpable. Spine normal with no tenderness or swelling. No supraclavicular swelling. Renal angles were non-tender with no swelling. On Percussion, there was a dull note over the lump, and liver span was 12 centimeters in the right midclavicular line. There was no shifting dullness. Bowel sounds were normal. On digital rectal examination, there was no growth palpable, there was no nodule. Normal feces mixed with blood. Normal feces were seen, no blood stain, I'm sorry. No fissure or hemorrhoids. On proctoscopic examination, there was no hemorrhoids or growth visualized. Summary, 39-year-old gentleman with symptom of left lower abdominal pain for 1 month with a firm, hard intraperitoneal mobile mass in the left iliac fossa with no rectal growth or hemorrhoids visualized on proctoscopic evaluation.
Yeah. Why do you think so? You have put up the diagnosis also. Go back. No, I'm sorry. Go back. Yeah. Again, I'll come back to the question. Why you think still it's a colonic mass? Because that's your diagnosis, provisional diagnosis. You have put up differential diagnosis also. Why do you think it's first of all a colonic malignancy? He has no constitutional symptoms at all.
Yes, sir.
So before she actually goes on that, I think saying carcinoma left colon is a very dangerous diagnosis. We are not pathologists.
Yeah.
So you should not be making a provisional diagnosis of carcinoma left colon. You can say neoplasm, you can say, malignancy. How have you put it as carcinoma left colon?
Understood, ma'am. Yes. Okay.
Yeah.
Yes,
And can you explain your other differentials? I mean, you've just put it there to kind of complete the list because it's really not making much of logic in the way the case is presented. Can you justify each of your differentials?
Ma'am, with pain in the left lower abdomen and on examination, there is a hard mobile lump, intraperitoneal lump in the left iliac fossa, not going into the pelvis. So from that, the source of the swelling, the site of the lesion can be most likely colon, distal colon, the descending colon sigmoid. So as it is a hard mobile lesion, I go in favor of malignancy. The most I've put the most common diagnosis as my provisional diagnosis. It could be just a lymphoma.
Dr. Lakshmi, sorry to interrupt you. The left-sided colonic growth, have we ever palpated?
Exactly.
Sure.
What kind of growth do you see on the left side?
Annular constricting growth.
Annular constriction growth.
Constricting growth.
We'll call napkin growth.
So very rarely we palpate such a huge mass. The right-sided masses, yes, they're all big masses. You can palpate. Number one. Number two, how common is the stromal tumor in the large bowel?
Less than 5%, except
So
adenocarcinoma.
very rare diagnosis. I'm sure you must have not seen.
Stromal itself, itself is less than 3% to 4% in GI.
Yeah. Then the lymphoma of the large bowel, I have a lot of objections for this. It is not a clinical diagnosis, Dr. Lakshmi.
Okay.
And what small bowel tumor, I don't think, because he said there's restricted mobility. And he has no any GS symptoms.
Nice.
You have any comments on this?
No, sir. No.
So lymphoma, do not put. It's not a clinical diagnosis. If the patient has a lymphadenopathy, say in the neck and abdomen, there is a mass, maybe you may be correct in saying that probably this could be also a non-Hodgkin's lymphoma of the large bowel. And gist of large bowel is again, it's rare disease. So maybe you can just put in a mass in the left iliac fossa. Probably since the mass is nodular and some restriction mobility. So it could be as well from the mesentery, colonic mesentery. In the absence of any GS symptoms, in this patient, my diagnosis would be a mass arising from the mesentery, probably, and a gist, probably any other benign lesion. He has no constitutional symptoms like loss of weight, loss of appetite, no GS symptoms.
The other thing which I would just like, since you all mentioned undescended testes, I think it's in a younger individual, one could also keep into this thing the fact that it could be a unascended kidney. Of course, the history would be different, but somewhere in the history, I think that could also be mentioned, because that's the only other mass I can kind of think of in that area. I agree that, lymphomas and this thing of the large bowel and cysts are extremely uncommon. So to put that into a diagnosis is making us take you on a path which I'm sure you don't want to go into.
Mesenteric cyst is unlikely because
Mobility, I was thinking.
yes. So it's freely mobile along the axis of the mesentery. So unlikely.
Could going for a duplication, non-communicating duplication cyst.
Yes.
That is more common and more likely to present this way.
Yeah.
Rather than carcinoma. Carcinoma is out. Young patient, no symptoms, palpating a lump, almost out. Very difficult to accept it. I don't know. Okay, I think so. Can
He has
continue.
no hematological symptoms also, no? Like a spleneculae or some that exercise spleen, something else, other things going there. But the patient had no other symptoms of the hematological symptoms also. He's not anemic also, no?
Not
But why do you still want to think it is a carcinoma or malignancy condition? Anything which you are having the mind for to say that it is definitely a malignancy?
only the hard nodular mass, sir, hard nodular intraperitoneal mass in the freely
Most of the
mobile
time,
mass.
colon will not produce a very hard mass. And most of the time, it is not an exophytic growth. It is any growth inside the colon is a intraluminal growth. So where we are not be able to see a very, very hard. You can see, but not that very common to think it's in the colon.
Yeah, fecal.
Yeah. One thing, yeah, it could it be an fecolate?
Or a foreign body.
Yes.
Okay.
Fecolate? Could it be a fecolate? Like Lakshmi?
It is of size 7 × 5 centimeters, sir. And
We have seen what is the most important if to say clinical that it's not a fecolate.
he has normal bowel bladder habits, sir.
Then clinically, how do you differentiate
The
mass and
what is
Pitting,
yes.
pitting,
Lactaceous, not pitting.
It's called a sign of indentation.
indentation.
Lactaceous.
Cartesar is there.
Okay. So gist is possibility because you said nodular and no GS symptoms. I'm bringing it now because this patient does not have any GS symptoms and nodularity, little mobility is present. Probably. So could be an gist to the large ball. However, the incidence here is low. So that could be the diagnosis at the end, not in the beginning.
One point I'd like to add here for the students who are there, that although we are discussing and persistently we are maintaining that left-sided colonic mass is annular and right-sided colonic mass are usually proliferative, but usually it's not a hard and fast rule. In some patients in the right side, you find obstruction, which is a feature of left colonic mass. We see it on the right side patients who have presented with intestinal obstruction, subacute obstruction or acute intestinal obstruction. So I feel when a patient has got a hard nodular mass in the left lumbar region or left iliac fossa, we cannot rule out a malignancy of a hollow viscous organ in that region. So I thought that we should not totally disregard, we may consider it lower in the possibility, but the problem here is that we do not have any other condition which can actually favor this sort of history and physical findings. So it becomes in these patients a diagnosis of exclusion rather than diagnosis of inclusion. So that is one of the points I would like to stress out, because when classical findings are present, it is very easy to make a diagnosis. But when classical findings, whether in history or examination, are not present, then we have to rely heavily upon disease of exclusion. So for the students who are there, it is not exactly a hard and fast rule that always it will be annular and always it will not be palpable, because we have seen so many patients with left-sided colonic masses which are large enough which are carcinomas which are palpable. So it can happen both ways. More often it will not be palpable, but rarely it can be palpable. Right-sided colonic masses, they do not produce intestinal obstruction often, but sometimes they can lead to intestinal obstruction because you can get many times in endoscopy you have seen there are annular growths in the right colon or ascending colon or the cecum. So this is the point I just wanted to highlight. As far as the lymphoma is concerned, as it was mentioned that we mentioned a diagnosis of malignancy or we mentioned a diagnosis of a mass of a colon. In general, I thought that is not acceptable diagnosis in most of the examinations, because if you have a mass in the epigastric region, the first diagnosis becomes carcinoma of the stomach, and we don't say that it is malignancy of the stomach, because malignancy of the stomach can include carcinoma, it can include GIST, it can include lymphoma. So usually we make a diagnosis because, as all of them have pointed out, less than 5 to 10% of these malignancies fall into the category of GIST or lymphoma, whether it is stomach or whether it is the colon. So it's 90 to 95% times carcinoma. That is the reason on clinical grounds we make a diagnosis of carcinoma. I just wanted to highlight a few points. Thank you very much.
Lakshmi, you can take solace that these kind of cases will not be put in your exam, just for discussion here. Also, if it is a CA colon, there has to be some symptoms. Such a large lump without any other symptoms other than pain is slightly okay. I agreed with Dr. Professor Kate that it could be, they can present with lumps, but with no other symptoms. I mean, just not being able to associate. Anyway, let's go on. Let's see how it turns out.
So just a point on the carcinoma. I think usually most examiners, including me, would not like a pathological diagnosis to be made, however rare or common a disease is. It usually tells the examiner that the candidate has seen the patient and knows and is aware of the diagnosis. And it can just, so I think for the general well-being of the candidate, it's better to call it malignancy and then take it from there, and maybe and then say the differential would be a carcinoma. But saying carcinoma upfront in a diagnosis is something I don't agree with.
Dr. Birappa, your comments on that, please.
Yeah, I agree with you also. Not say on the left side it presents with obstruction, right side present with an obstruction. I agree with you. Sometimes, mass we have seen on the left side and no mass on the right side. It happens. But carcinoma, I also feel that malignancy, maybe, yes, that includes all those carcinoma, GIST and other things.
Proceed, Dr. Lakshmi.
Can I proceed, sir?
Yeah, please.
Yes. To confirm my diagnosis, I would first like to do an ultrasound, followed by a contrast-enhanced CT of abdomen and pelvis.
Lakshmi, you said it's your first diagnosis is a colonic mass.
Yes, sir.
So what should be the first diagnostic investigation?
CT. Contrast-enhanced CT. From less invasive to a more invasive.
Now you said first is ultrasound, second is CT, and third is colonoscopy. Your first diagnosis is colonic
mass.
Malignant colonic lesion.
Colonoscopy.
Ultrasound or CT?
Colonoscopy, sir.
Why not ultrasound? Or why not CT scan and then go for colonoscopy?
Ultrasound is not sensitive for colonic pathologies.
For any bowel pathology?
For any bowel pathologies, yes.
Okay.
Colonoscopy gives us a diagnosis because we'll be visualizing the lesion. Like, it gives us a straightforward diagnosis of the pathology, because
one is we'll know the site of the lesion.
But however, in this case, since we are not very sure that it's a colonic mass, I think the ultrasound will help you to rule out other things.
Since you said her first diagnosis is colonic mass.
Ultrasound will not confirm the diagnosis, it just give you a guidance.
Since you said it's a colonic mass as the first possibility, so hence, if she's thinking colonic malignancy is the first possibility, then colonoscopy should be the diagnostic investigation.
I think it's fair that what is the most common investigation, very easily done, that you can do if you're suspecting a colonic malignancy before we decide to go on for an ultrasound or a CT scan or a colonoscopy? Is there something simple that you can do?
Serum CA levels.
No. Anything that's used as a screening procedure in most countries.
Fecal blood, occult fecal.
So you could do that, and I would think yes. I mean, not an ultrasound and a CT if you're expecting this thing, but a CT scan is a routine this thing for staging or whatever else, confirming of diagnosis. So I would agree on that as the first investigation before a colonoscopy. That's my point of view.
I think an ultrasound is the extension of clinical examination, should be done first, followed by a rectal exam for a proctosigmoidoscopy or a colonoscopy. I don't know about others. Even
Vikram, if she has an diagnosis
usually we teach them the same way, that we usually go from a simple investigation to a more complex and non-invasive to invasive. So as in this patient, diagnosis is not very clear, I would consider an imaging investigation first before we do a.
She had said a mass which is arranged in the left iliac fossa, something else, not a colonic lesion. Probably, yeah, true. You do an
no, like one of the diagnoses we have put as small bowel tumor. So small bowel tumor may not be picked up on colonoscopy. So that sort of thing. That is what I thought, that that's a very mobile mass, and any mobile mass, potential diagnosis of small bowel cannot be ruled out. So if CT shows that it's not exactly colonic but small bowel, then we might have to do some other type of follow-up investigation. That is the reason I thought. But what you said is also correct, that in case if you're very reasonably sure, colonoscopy can give you a direct diagnosis. But usually our teaching is that non-invasive to invasive. So colonoscopy usually we tell it in the end rather than upfront, because it's like a patient has been seen by a resident in the OPD and he suspects a colonic mass and immediately gives a appointment for colonoscopy. That is not usually we follow. That is the reason. So we first consider imaging and that's please go ahead.
No, the other thing is also, if we are seeing more and more younger patients coming to us with malignancies, and if it's there in the back of my mind, I would also like to know the status of the liver and things like that for metastasis even before I undergo a colonoscopy on the patient. So it will give me a better staging of the disease process as well before I actually go in for an invasive procedure.
Madam, but in the list of investigations, the first should be to confirm the diagnosis, next should be staging, and the last should be the supportive. So that is the reason.
A CT is done, A, to localize the lesion, B, to understand this thing, and in the same setting, we can also see if it's spread anywhere. And of course, we confirm it with
I totally agree with you.
Colonoscopy, of course.
Dr. Birappa's point was to first confirm the diagnosis if you are reasonably sure. And in clinical examination, if you don't have varied diagnosis, then why not go ahead? Because that's the investigation which will give you the final diagnosis. Literally,
no, I agree with what you said. I mean, we would follow the non-invasive to invasive, and go into a colonoscopy after a basic radiological imaging. That's probably what most teaching colleges do. So I think for the students, it makes sense to say it in that order.
Even bowel preparation will be needed. So it will take some time. So better to get some investigations, right?
I would say, because my differential diagnosis, the first diagnosis is CA colon, an ultrasound will give us all the information which Dr. Shilpa is looking for. And to confirm a colonoscopy, a CT scan is just to look for the spread for staging, like Professor Kartik said. So this thing would always be ultrasound, colonoscopy, and CT. I mean, rest others. But I think it's just
please go ahead.
Change algorithm. We can allow her to proceed, I guess.
Please go ahead with what you've seen.
So can I display the CT images? On CT, is my cursor visible, sir?
Yeah, it's visible.
It's visible. It's visible.
There is an irregular heterogeneous enhancing wall thickening seen here in the distal descending colon. With the extraserosal involvement, fat stranding seen in the form of fat stranding and perilesional paracolic nodes in this. And in this view, we can see the wall thickening along with its infiltration into the anterior abdominal wall. Here. Again, this image shows the circumferential wall thickening with paracolic nodes. The growth is from descending colon, from the lower descending colon, reaching almost the sigmoid, with proximal bowel dilatation. Here it's fully circumferential and proximal bowel dilatation is also there.
Lakshmi, would you like to change the diagnosis now? Pathological diagnosis. We'll come to the pathological diagnosis. Still think it's a carcinoma, or would you like to have some differential diagnosis?
This is a wall thickening, a circumferential wall thickening of the colon, sir. So I would go in favor of carcinoma of descending colon.
Would you like to entertain lymphoma now, because their perirectal lymph nodes are there? Thickness is more than 1 centimeter. She said it's 1.3 centimeter thickness. Would you like to entertain the lymphoma?
Lymphoma can also be a possibility, sir. It can also be a possibility.
With an obstruction, you know.
Okay.
Tuberculosis.
Tuberculosis.
Colonic tuberculosis. Now let's go back to history. A young man with no GI symptoms and CT showing this kind of a picture. So could it be a tuberculosis? However, colonic tuberculosis incidence is very rare.
Yes, sir. Not sure, sir.
This is based on CT scan. You can give a differential diagnosis like lymphoma. However, your diagnosis may be correct, but tuberculosis is also another differential diagnosis, not as in a first diagnosis, but at the end.
Okay.
Yeah. What next? What is important? You are only seeing the.
There is no free fluid, sir. There is no free fluid. There are no distant. There are no distant mets.
I'm not seeing the liver.
I just did not. I've mentioned that there are no distant mets. I did not put those films.
Important. You should put those because there's significant pericolic lymph nodes are there. So we'd like to see the liver also, whether there are lymph nodes or not. So what next?
He had a serum CA values of 8.3, which is elevated. Colonoscopy was done, which showed a circumferential polypoidal growth at 28 centimeters from anal verge. Scope couldn't be passed beyond it. Biopsies were taken. Biopsy was reported as well-differentiated adenocarcinoma.
Would like to do a PET CT now.
PET CT, as there are the CT findings are pretty clear. So because there are no confusing features in the CT, I would not like to go ahead with the PET CT now. So with the elevated serum CA levels, colonoscopy and CT findings almost confirming my diagnosis.
Is CA levels are raised?
Yes, and the colonoscopy is also showing a growth.
Is there a role for a PET CT? I'm asking
that. Lakshmi, the question is not for the diagnosis. PET is not done for diagnosis. PET is done to find out the dissemination of the disease. Diagnosis is almost clear. You already put the biopsy report there. Question is whether you'd like to find out if the patient has got any further dissemination of the disease, which has not been picked up by the conventional imaging investigations.
If say if don't want to do it,
good enough for liver mets and lung mets.
I'm only asking because we've not seen a liver lesions and we have not seen lung. So that's the reason why I'm asking. If the CT had showed no liver lesions, no lung lesions, it's only lesion. I mean, lesion in the left side of the colon with some pericolic nodes. It's fine. So what is the staging?
Staging is T4B.
May I interrupt one more time?
Please.
Yeah, so this is another reason why we ask for a CT, because a lot of times patients are ill prepared, and the standard answer that is given by the gastroenterologist, I mean the junior who is that the scope couldn't be passed beyond the thing. So we don't know whether we are dealing with multiple growth, single growth, other things. And since we have a CT very easily available, and ultrasounds are done by juniors, and that's just a protocol that we follow. So we do the CT much easier to do, and then we go in for a colonoscopy and the other things. Just a point.
No, this kind of patient who has no obstruction, I don't think a direct CT scan is necessary. We definitely do a colonoscopy. He is not in obstruction. The CT findings may be showing in a dilated colon. That's different question.
This patient was an obstruction. The colonoscope did not go beyond the growth.
That is okay. After CT,
so
after colonoscopy,
it happens very often. So, that's the protocol we follow in our institute. Of course, everybody must be having their own methods of following it.
Fine. No issue. Yeah. Lakshmi, what next?
Yes,
said P4 and
P4P and 1.
And 1 M0.
Yes, M0.
So what would you like to do now for this patient? Biopsy is positive.
Yes,
we don't want to do there's no need for an PET CT because CT liver and chest seems to be normal.
Yes. In this case, it is a low. I like to, of course, discuss the case in a tumor board, and I would like to consider the point in this patient's followed by reassessment and resection. Sir?
Can you please repeat?
Yes, sir. Yes, sir. In this patient, currently not, I would like to consider the patient for neoadjuvant chemotherapy, 2 to 3 cycles of FOLFOX, and then reassessing and considering a resection based on the response.
So you mean you go for an preoperative neoadjuvant and chemotherapy followed by a surgery?
Reassessment and surgery, yes.
So this patient colonoscopically, they couldn't negotiate beyond the tumor.
Yes, sir. Yes,
so is
yes,
there a need for a surgery initially and then go for an
yes, I can. I'll do a diversion. I will do a diversion procedure, then consider neoadjuvant, and then for a curative resection, reassessment and a curative resection.
Why can't exercise? Why not do an since there are no any metastasis? Why can't you do a resection and do an end-to-end anastomosis or anastomosis and proximal diversion? We are hesitating to say that surgery is not a first line of treatment. He has no ascites. He has no liver metastasis radiologically. So why can't we do it? Surgery. Why are you saying it's neoadjuvant chemo or colostomy and neoadjuvant chemo and then surgery?
Patient has no bowel obstruction, no? That is.
Clinically, no, sir. But...
Okay. Clinically, no means no.
Lakshmi, you need to justify. I mean, he's asking you a question. So as an examiner, if somebody asks you, you have to justify why you feel the need to give NACT in this patient and what are the drugs that you use. Are there any NCCN guidelines which kind of tell you that, yes, we must use chemotherapy, NACT before a tumor which has got a high CEA levels and which has got an extra serosal spread most likely. So you have to tell us all these things.
NCCN, according to NCCN guidelines, he is an ideal candidate for neoadjuvant therapy, sir. A T4B lesion to reduce the tumor burden and to bring it down. He's an ideal candidate to get neoadjuvant chemotherapy, followed by a curative resection.
What is the NACT you'll use in a colonic mass?
FOLFOX regimen or capecitabine, 2 to 3 cycles of either of those.
Yeah, and it's likely to go into obstruction or post chemo, or is it not likely to go into obstruction?
It's likely to go into obstruction because of the tumor lysis and swelling. Yes.
So therefore, the need for a
Diversion.
diverting. So would you do a diverting colostomy or would you do a diverting ileostomy?
As it is a temporary temporary diversion procedure, I would like to do an ileostomy more than a transverse colostomy.
You need to be a little more confident of your answers. Yeah. So even when you open up, if you do find other polyps, everything else, an ileostomy is actually helps the functioning much more than a colostomy does. And it's easier to do, and it's easier to put back as well. So yes, therefore a diverting ileostomy and then NACT, right? Okay, go on.
After NACT, 2 to 3 cycles of NACT, I would be reassessing the patient for the disease.
How do you reassess, Lakshmi? So you've been saying that I'll reassess 2 cycles of chemotherapy, FOLFOX, and then would you like to repeat CT or would you like to do a PET CT? I would like to know from other faculty also whether you do PET CT. We do PET CT in a patient who has a locally advanced disease, T4 lesion and N2 with this kind of an obstruction. We do PET CT and do a colostomy, go for a neoadjuvant, as I said, and then repeat PET again. So there is a difference of opinion. PET CT, we think if any nodes or any metastasis in the lung or liver, so then the intention of treatment differs. Whereas if there are no lesions in the liver and lung and only confined to the colon, then intention is different. Vikram, do you agree with me?
Yeah, but the problem with PET is, especially the diagnostic stage, is I agree with you. There are two problems. One is the yield, and the second thing is the false positivity rate. But that becomes a little difficult because sometimes you get the increased uptake in areas which may not be malignant. And the other thing, as I said, if the imaging is clear in those circumstances, there is a possibility that PET may show it in some patients, but the number of patients might be too less to justify a PET in all the patients. But I totally agree with you that it's a difference of opinion. As far as just now, as I said, for surgery also, there are people with very minimal involvement, as you said, in this particular patient. People might go ahead straight away with upfront surgery also, because one of the difficulties with the neoadjuvant chemotherapy is we should not always presume that the patients will always respond to that neoadjuvant chemotherapy. While we are waiting for the neoadjuvant chemotherapy to go on and if the tumor progresses, the lesion which is receptacle might become undissected. So that is one of the things that we can lose. So both ways it can be argued. So that is how is my opinion.
Yeah, I think we all have our opinions, and of course we all practice them. But for an exam or this thing, I think the guidelines need to be kind of mentioned, standard guidelines. And of course, each person may have their own personal take on it. We don't do a PET CT, we do a CT, and then before we actually go in, we do a diagnostic lab to ensure that there's nothing on the liver and thing. And so I guess everywhere there are different, but I mean, if the candidate wants to play it safe, it is easiest for them to mention the guidelines that exist today for colorectal cancers.
Yeah, that's better. That's better. If you quote NCCN guidelines and then say this is the protocol for this patient. Yeah, any questions?
So you've done all of this and then you've decided to take up the patient for surgery. And you find that he has a couple of mets in the liver. So what would be your further plan of action?
Yes, ma'am. In the colorectal, in colorectal malignancy, liver mets are, if the liver mets are resectable, we can still go on with the curative intent. So I would like to now go for a PET scan and
see the percentage of liver mets that happens in a colorectal, especially in a left-sided colorectal cancer.
30% of them
Yeah,
will have.
it's quite high. So yeah, if you can do so you can go for both in the same sitting, liver and colon.
Yes, yes, ma'am. If synchronous lesions, we can go ahead. There is an option of going ahead with the both at the same time, addressing colon and liver at the same time.
If they are really tiny meds, is there any other alternative to surgery?
Yes, ma'am. There are for the liver meds, there are directed therapies like hepatic arterial infusion of 5FU or chemo, cryoablation or other ablative methods are there.
Yeah. Oh, good.
If you find peritoneal nodules, not liver metastasis, so where do your treatment differs?
I can still aim at curative. I'll do a resection followed by a HIPEC, sir. If the PCI index is less than 15, I believe, I can still go ahead with the resection and followed by HIPEC.
Lakshmi, what is the current role of HIPEC in malignancy?
Following a cytoreductive surgery to address the leftover disease, you can in colorectal malignancy with peritoneal carcinoma. Excuse me, ma'am. Sorry, ma'am. Can you please repeat the question?
No.
Hello.
There are a couple of papers which have covered the mortality.
Am I audible, sir? Hello.
Yeah, you're audible. Carry on.
Carry on.
Lakshmi, can you put the findings in this patient before we close? It's almost 9 o'clock, beyond 9 now.
The intra findings, sir.
Yeah.
Okay. We took him up for resection for a diversion. 250 ml. 10x7 hard mass was found in the sigmoid colon with multiple parietal wall deposits in the right and left iliac fossa. Diffuse nodules in the greater omentum small bowel mesentery. So we did a transverse colostomy, a diversion procedure, and came out. We did not do a resection on this patient.
So what will be the next follow-up of this patient? So you will send him for a chemotherapy.
Yes.
So what regimen?
FOLFOX or capecitabine, palliative chemotherapy.
Palliative, it is a palliative chemotherapy. Good.
Palliative.
And how do you follow up?
This is a stage 3 disease, sir. I would stage 4.
Nodules in the greater omentum.
Yes.
Ascitic fluid is there. So
yes,
M1.
M1, stage 4 disease.
Yeah, M1 disease. Yes.
I like to follow up the post palliative chemotherapy. I like to put the patient on follow up with serial history examination and CA levels every 2 to 3 months for the first 6 months for the first 2 years, and then followed by every 6 monthly for the total of 5 years.
Would you like to review the biopsy report? Would you like to take some more biopsies from the greater omentum nodules and send it for a biopsy? Look for what kind of a lesion. Moderately well differentiated, grade of the tumor.
Yes, sir. It was already well differentiated adenocarcinoma, sir.
Okay. Fine.
With
the immunotherapy.
Yes, so you can also put targeted bevacizumab or pembrolizumab along with the FOLFOX regimen.
What do you think should be maybe the prognosis of this patient?
Prognosis?
With all the facilities available.
With no curative intent, less than 6 to 9 months, sir.
Now, again, it will depend on the response to the chemotherapy. Okay, even if a patient has got a disseminated disease, each disease behaves biologically differently. So if the response is good, the patient may have even in this setup, a reasonable prognosis. If the response is not good in those circumstances, then the prognosis will be dismal.
Okay.
That is the answer which will be expected.
Okay.
Thank you,
Follow-up of the patient, history examination, serial CL levels every 3 to 6 months for the first 2 years. And every 6
your
months.
levels to fall in this Lakshmi after surgery?
No, sir. The disease, because the pre-op CA value is already high and he's a secretor, and the disease is still inside
So
the
we don't
abdomen.
expect there is a fall unless he's responding to chemotherapy.
And imaging,
Yeah.
sir, every 6 monthly, sir, 2 years, and every 6 monthly for 2 years. And PET CT can also be done on 6 monthly basis for this patient, sir.
So you agree now?
That what you're saying, Lakshmi, is actually when you do a potentially curative surgery, that sort of follow-up. Okay, when you have a patient with this sort of disseminated disease, and even if the patient has got a response to chemotherapy, the follow-up will be more quicker and more frequent with more investigations. Okay, so what you're telling is when you have done a complete resection, R0 resection, in those patients we follow up the way you are mentioning. Okay, what you said is first 3 monthly, 6 monthly, 1 yearly. Once you have control of the disease, you can increase the span of follow-up. But here it's unlikely that that sort of thing will happen. Even if the disease theoretically reduces to something like an R0 pattern, you have to have a very close follow-up, because whatever has responded can again come back, and you will have to think of some other type of therapy in these patients. If you're only given chemotherapy, you might have to think of targeted therapy as the follow-up treatment. So that is the difference when you are treating a patient with a palliative intent and treating a patient with potentially curative intent.
Lakshmi, any role of cancer vaccines in young patients with probably family history?
Yes, ma'am.
Any role of cancer vaccines?
Cancer vaccines.
Are you aware of any vaccines that exist?
No, ma'am, no, I'm not.
Okay. I think we can stop, right?
Yeah,
Yeah.
Dr. Kanagvel, if he is there, so if
thank you,
time
Lakshmi.
is up, 9, 10, yeah, you can stop here.
We'll move on to the
sir.
next. We'll move on to the next case.
With the permission of the faculty, we move on to the next case. I request all the faculty to stay back, and also Lakshmi to stay back for the next case discussion. Can I invite Dr. Karthikeyan from Coimbatore Medical College to share his PowerPoint? Thank you, faculty.
Good evening, respected faculty and all the participants of this conference. I'm Dr. Karthikeyan, MS postgraduate from Coimbatore Medical College, and with the guidance of Dr. Srinivasan, my chief, and Lakshmi Narayani, my HOD, I hereby present the case of right iliac fossa mass. Can we proceed, sir?
Yeah, we are unable to see your PowerPoint.
One second.
Yes, you are good to go, ma.
Our patient is a 52-year-old gentleman coming from Erode, Tamil Nadu, an electrician by occupation, and he came to the hospital with chief complaints of abdomen pain for the past 1.5 years, and palpable mass in the abdomen for the past 1.5 years, and bleeding during defecation for the past 6 months. Patient was apparently normal 1.5 years back when he developed abdominal pain, which was insidious onset and continuous, and fell towards the right lower abdomen. It was dull aching type of pain, and it is increased in severity for the past 1 month. It made him come to the hospital, and he's been taking over-the-counter analgesics, which reduces the pain, and there was no referral radiating of the pain. And palpable mass per abdomen, he noticed the mass incidentally. While he developed pain, he held his abdomen, he found that there was some sort of swelling or mass there, and it was present in the right lower abdomen. It was initially small in size and gradually increased in size to attain the current size. And history of bleeding during defecation, it was dark colored stools dark colored blood mixed with the stools, and there was no history of pain during defecation. And each time he has such episodes, it lasts for 4 or 5 days and settles on its own. Yes, 2 or 3 episodes per month. And he had a loss of unintentional loss of weight, approximately around 10 kgs over the past 3 months. And he had generalized tiredness for the past 6 months. And there was no history of constipation or abdominal distension, no history of fever or evening rise of temperature, no history of chronic cough or back pain, no history of loss of appetite, no history of jaundice or any other swelling in other parts of the body. Patient has no known comorbidities such as diabetes or hypertension. He's not on any regular medications per se. And he had surgery done for the fracture of right thigh, which was around 30 years back. And he had records for that. And there was no history of any known drug allergies. And person is consumes mixed diet. His sleep and appetite is normal. His bladder habits are normal. He's a chronic smoker, smoking around 8 to 10 cigarettes per day for the past 30 years. And he's a chronic alcoholic for the past 30 years. Yeah, there was no history of abdominal or any other malignancies in other members of the family or close relatives. And there was no history of tuberculosis in the family. So I summarize my history as a 52-year-old gentleman with chief complaints of abdomen pain and mass in the abdomen for the past 1.5 years, associated with bleeding per rectum for the past 6 months, and unintentional weight loss of around 10 kgs over 3 months with no history of constipation or vomiting.
Yeah, Karthikeyan. Can you just tell me, you can go back? He said he has a melena, history of melena. That's what he said.
Yes, sir.
It's not a fresh blood.
It does not have frank bloods. It's dark brown to red is what he's saying, sir.
Huh, okay. Then you can mention that.
Yes, sir.
Melena.
Okay, sir.
So it's better.
Yes.
2 to 3 episodes per month. Okay. So what do you think the possibilities are in this elderly male? You heard the story of all the colonic pathology and colonic malignancies.
Yes.
So it should be easy for you now. So what do you think the problem is?
So it's probably a right-sided colonic malignancy, which is presenting with blood loss and right-sided mass in the abdomen, sir. So he could be having anemia, and that's why the generalized tiredness is there. And because of the malignancy, there is some loss of weight as well. And
weight appetite as well as bleeding per rectum, melena. Any other differential?
One of the points I wanted to ask is, this is very rare for a patient to palpate a mass. That is what you have mentioned.
Yes, sir.
I have not come across patients mentioning about this. It's very rare unless and until they mention that there was a mass-like feeling which changes the position in the abdomen. If something like that is there, then the patients are a little specific in telling. But overall, a patient palpating a mass, it's little, it's not so common. So you have examined the patient. Was the patient very thin-built or something like that, or
yes,
how was it?
He's a lean patient, sir. He has a flat abdomen, and
Okay, you don't have to show the examination findings right now. I just wanted to ask you,
yes,
because that's a little uncommon.
Yes.
The only situation where the patients typically mention about a mass which changes the position, there they can be a little more particular and they can tell which condition you get that. The mass will be in the right iliac fossa, then it might be lumbar region, it might be in hypochondriac region.
In cases of an mesenteric cyst that is mobile, that could be there, sir.
Now, why it should change the position?
Since the mesentery is attached only in one axis, it can move in the opposite axis.
The mesenteric cyst will not produce a mass in the right hypochondriac region.
Any possibility of intersusception?
Yes, sir. It could be there, sir. Since he's an old age male, there could be some leading point that has led to chronic intersusception.
No, that is the answer for the question which I asked. But in this particular patient, you think it's likely to be interception? You put the next slide or the previous slide. Can you note any point here which practically rules out interception?
Increasing in size over.
Not increasing in size. The second last point. See, interception patients, unless and until the lead point is due to malignancy, okay, then in those circumstances, it becomes a patient of malignancy. It doesn't no longer is an interception, but otherwise 10 kg loss of weight in 3 months. Is the patient sure about this point?
Yes,
10 kg
yes.
loss?
Yes.
In those circumstances, very unlikely. And what sort of bleeding is there in an interception? Or a classical description?
Red currant jelly is the classical feature.
What do you mean by that?
It is semi-solid in consistency and
not at all. Not at all. Red currant jelly has got a very typical description. What is it? And due to what? It's a mixture of blood, minimal blood with a lot of mucus. That is why it's called as red currant jelly. That happens because of the intussusceptum getting compressed in the intussuscipiens, and a lot of mucus is exuded, and the capillaries, fragile capillaries, they break down, and you have minimal bleeding. And that blood and mucus mixture is called as red currant jelly. Very rare things, all these things. Anyway, we'll skip all these things. Yeah, any other questions? Some people are asking questions.
Is there any other cause for this lump? It's not seen so commonly nowadays, but we saw it in our residency. Typically, the mother will also come and say, I felt one lump here, then it went there, then it went somewhere else in the baby's abdomen or the child's abdomen.
Any amoeboma or lymph node, mesenteric lymphadenosis?
Amoeboma will not move like that.
Lymph nodes, lymphadenopathy.
Huh? No. Why will that move? You heard of roundworm obstructions in children?
Yes.
It used to be very common at one point. So that typically they would all move from one point. So that would be a very typical history that the mother would come with.
Yes.
But other than that, yeah. Continue.
Yeah, go ahead with the examination point.
So I examined the patient after getting informed consent and in a well-lit room and ensuring adequate privacy and exposure from nipple to mid-thigh. The patient is moderately built and nourished. He is conscious and oriented and cooperative examination. He was afebrile and he was well hydrated. There was pallor on examination and there was no icterus, cyanosis, clubbing or generalized lymphadenopathy or pale edema. His pulse rate was 80 beats per minute, regular in rhythm and normal volume. Blood pressure was 120 on 70 millimeters of mercury. Respiratory rate 16 per minute and saturation was 97%. And on inspection, the abdomen was flat, umbilicus is central and inverted. All quadrants were moving accordingly with respiration. There was no scars or sinuses or dilated veins in the abdomen. There was no visible pulsations or peristalsis. Only orifices were free and the external genitalia was normal. And on palpation, all the inspectory findings are confirmed. And there was no warmth. And there was a mass palpable in the right iliac fossa region, measuring about 11 cross 6 centimeters in size, extending from 3 centimeters medial to the mid-clavicular line up to the anterior axillary line. It was roughly oval in shape, and the borders were well defined, the surface was nodular, and was hard in consistency. And there was limited mobility along the transverse axis, and mild tenderness on palpation of the mass was there. No non-pulsatile, and the lower border of the mass is palpable, and the plane of the swelling is intra-abdominal or retroperitoneal. And there was no hepatomegaly, and no other masses were palpable in the abdomen. Corneal orifices were free, and there was no palpable supracapitular lymphadenopathy. And the external genitalia were normal. On percussion, there was a dull note over the right leg region. Rest of the abdomen was resistant to tympanic. There was no shifting dullness present. On auscultation, bowel sounds were heard normal. On perrectal examination, the sphincter tone was normal. There was no anal tags or increased tone. There was no palpable growth or ulcer or deposits in the pouch of Douglas region. And fecal staining was present, and there was no blood stain on examinations. And the examination of right lower limb was normal. There was no edema or musculating or functional deficit. The distal pulses were normal, and the examination of spine showed no tenderness or palpable gibbous. And other systemic examinations were normal, and there was no uneventful. S1, S2 heard normally, and respiratory system violently identity equal. No added sounds were heard. And central nervous system, there was higher mental functions normal, no focal neurological deficit. And coming to my provisional diagnosis, a 52-year-old gentleman.
A small interruption. You've gone through your history like, I don't know, the Rajdhani girls thing, very, very confident. But again, when you're talking about palpation, you need to mention temperature and tenderness. Your tenderness comes way at the end of the story.
Yes.
Yeah. So the first thing that will be mentioned will be increase in temperature anywhere in the quadrants, and whether there is any tenderness, localized or generalized. Then you go ahead with the rest of your exam. Yeah. Otherwise, yeah, it's just run through like.
So, 52-year-old gentleman with chief complaints of abdomen pain and masked abdomen for 1.5 years, associated with bleeding during defecation for 6 months, and no signs of obstruction, and 11.6 centimeter hard, well-defined irregular mass in the right iliac region, probably right-sided malignancy of the colon.
But again, bleeding per rectum during defecation is something different. And history of melena is something different.
Yes.
Which one is this patient has?
Melena.
Okay. It's not bleeding per rectum or during defecation.
Yes.
Okay. So, would you like to think of any other differential diagnosis other than carcinoma of the colon?
It could be
or malignancy of the colon.
Tuberculosis of the ileocecal region could be there, sir, in case of hypertrophic variant. But my examination findings ruled out tuberculosis. And
what findings ruled out ileocecal tuberculosis?
Sir, if we had mass in the right leg region, it's probably because of a hyperplastic type of tuberculosis.
Tuberculosis can have a mass in the right iliac fossa.
And in that
case, can have history of loss of weight and appetite. You can have. Then what else?
In the hyperplastic variant is not usually associated with bleeding or melena.
Very good. Very rare. Very, very rare. Tuberculosis presenting with GI bleed is very, very rare.
If you had ulcerative type,
that goes against tuberculosis.
Yeah, in ulcerative mass formation is uncommon, and in mass formation, bleeding is uncommon. That is how we have to think about it. Any other point which is not in favor of tuberculosis? You have it on this slide itself.
No signs of obstruction is favorable.
Yes, so the large masses there, you expect some degree of subacute obstruction. Acute intestinal obstruction is not common with ileocecal hyperplastic tuberculosis.
Yes.
But a patient can have some symptoms of subacute obstruction, such as, what is it described as? What is it called as in history?
Borborygmy, yes, gurgling in the...
Borborygmy, yes. What is borborygmy?
Patient before having obstructive symptoms as vomiting or distension, they usually have the gurgling sound and that he feels.
Yeah, associated with colic abdominal pain. The patient can appreciate his or her own bowel sounds and associated with colic pain that is suggestive of a subacute obstruction. So that is likely to be possible. Okay, in this sort of mass, which is reasonably large in size.
Yes.
Could it be an inflammatory bowel disease like Crohn's?
It could be, sir, but it's an elderly man, which is uncommon for.
No.
It could be, sir.
Can you say why not?
It will have a chronic history.
Not necessarily that you have to accept examiner's diagnosis always. So why not? Why not? What are the points against inflammatory bowel disease?
A large mass that is recently progressed in size does not favor inflammatory bowel disease.
He doesn't have any loose motions. no small bowel diarrhea, so they may not have an overt GA bleed. They may have slow bleed, but they may not have overt GA bleed. So, and young people, he's an elderly male. It's unlikely. Okay. And he said the mass is tender.
Yes, sir. He does.
We are suspecting a malignancy of the right-sided colon. How do you explain the tenderness?
There could be some extent of tumor necrosis that could be there that causes pain and tenderness.
No.
Any pressure on the nerves around visceral pain?
What? No. He said it's tender mass.
Yes.
If you're suspecting malignancy of the right-sided colon, the patient has a tenderness. What does it mean?
Colon
What
malignancy
complication it can lead to?
Appendicitis can be happening in cecal malignancy that can cause pain and tenderness. Or
that's an acute presentation of a malignancy. Can it be a localized perforation? Number one. Number two, peritoneum involvement sometimes can cause a pain, tenderness?
Localized perforation or abscess collection that happened recently.
Yeah, it can happen.
Yes.
Appendicitis, yes, sometimes they may present with an appendicitis. So, but that's an acute presentation. Yeah. Any other differential diagnosis, or you stick to malignancy right-sided colon?
Sir, from my history and examination, I've rolled out other differentials. They're usually for right-sided colon, right-sided iliac region, we could have lymph nodes or retroperitoneal tumors, but all of that don't correlate with my history or examination. So I stick to my professional diagnosis.
Fine. So how do you investigate?
Sir, initially I would do investigations to confirm my diagnosis. I'll start with non-invasive investigations and then progress to investigations. So I'll do an ultrasound abdomen as a screening method as an extension of my examination. Ultrasound abdomen can find out if there's any collection or abscess or anything else that could present as acute pain or anything. And after that, I would, if the ultrasound is definitive, I could go straight to colonoscopy.
It cannot be definitive in a bowel pathology, Dr. Karthikeyan. So I would agree, okay, as a part of the screening you want to do is to know whether there's a liver lesion. So I think it's fine, but it will not be definite. It will show only if the good radiologist is there, he'll show there's a thickening in the intestine.
Yes.
And if there's an ascites, liver lesions is there, then he will say that they're all the positive findings. But it cannot be definitive investigation. Okay, please go ahead.
I would do a CCT abdomen pelvis to find out if there's any lymph node mets, and my definitive investigation.
Again, Karthikeyan, that's not a definitive diagnostic investigation. I agreed for an ultrasound, but not for an CT scan.
Definitive would be a colonoscopy, sir. A colonoscopy biopsy.
I do not know if you are all taught like that. Sir Vikram, you need to clarify this.
Usually, that's what is the route we take. That's why he's telling it, but it's okay.
CT after ultrasound?
Definitive investigation would be to do a colonoscopy and biopsy, and to screen the rest of the colon for any synchronous lesions that could not be picked up on imaging investigations.
The colonoscopy is for what are the things you look for in colonoscopy? One is said synchronous lesion. Then what else?
Any polyps in the rest of the colon can be fine.
Very good. Very good.
Yes, sir. And
I'll just interrupt here. Suppose you find one polyp in the region of left splenic flexion. Okay, single polyp is there. Looks like an adenomatous polyp. So, if you identify that, how that is helpful in the management?
After resection of the primary tumor, I will follow up that polyp that was existing, so that if there is any future, when I screen the patient on follow-up, I would screen if there is any changes in the.
No, let me interrupt you here. Okay, the answer is not correct. If you find a polyp, would you not remove it while follow-up polyp when you're doing colonoscopy? It will add only 5 minutes more to the procedure. Yes or no?
Because
would you like to retain the polyp? That's not the question I'm asking. You will remove the polyp. Definitely, you will do the surgery, what you are doing. In the follow-up, how this change in the presence of the polyp will affect the management. That's my question. I'll give you a hint. As far as surveillance is concerned, you have to answer.
And post-operatively, I'll watch the carcinogenic antigen levels, sir. If it's still not fallen or
that is done in all patients, no?
Yes, sir.
So the answer is that when you have a polyp in a patient, the frequency of colonoscopy in surveillance increases. Otherwise, colonoscopy is a very invasive investigation. So it is not done. It is done at 1 year and then straight with 5 years. But there, if you have a polyp at 1 year, and again, if you find a polyp, you will have to do it annually till you are sure that no more polyps are there. Okay.
Yes.
Adenomatous polyp is a pre-malignant condition. What is the incidence of malignancy in that?
In familial adenomatous polyp, it's 100% incidence of malignancy.
No, this is, I'm not talking of familial. When I say 1 or 2 polyps, it cannot be familial FAP. Is it? I'm asking if you have adenomatous polyp. There's something called as hematomatous polyp, no? Which is not a pre-malignant condition. Anyway, I think we are digressing. Proceed. So there's no polyp. That's it.
You've taken a biopsy and there's a lesion in the cecum. You've taken a biopsy and biopsy is a negative for malignancy.
If the patient, since the patient has symptoms of GI bleed and he has pallor, we need to do some therapeutic management for that. So I'll check the patient if he has any tuberculosis. I'll do an AFP and check the histopathology for tuberculosis.
பணம் கட்டியாச்சு. ஹலோ, நான் கட்டினேன். நான் பணம் அனுப்பிச்சிட்டேன் உனக்கு மறுநாளே. அதெல்லாம் நீ இங்கிலீஷ் நீ அனுப்பவே இல்லை. சும்மா சொல்ல வேண்டியது. அது நீ
Can you just mute your mic, please? Somebody's mic is on. Disturbing the presentation.
கேளு. இன்னைக்கு போய் பார்த்தேன். பார்த்தா ஏதோ மெயில்ல டவுன்லோட் ஆல் டிக்கெட் வந்துச்சு.
Yeah. The biopsy is negative. What did you say? Can you please repeat?
I will screen for other causes for such a growth and bleeding, sir. I mean, melena, sir. So, if it's other conditions such as tuberculosis, I will treat accordingly, sir. And if there is any intersusception, we will.
Only the biopsy is negative for malignancy. I did not say that biopsy is positive for tuberculosis. You have done a colonoscopy, no lesions were found, but except cecal growth, which you took a biopsy, but that's negative for malignancy.
Yes, sir, but we could screen the biopsy for any caseating necrosis.
The answer should be, you should repeat the biopsy. Okay, fine. So what are the investigations done here? Can you have the investigations done?
So, and those are the investigations I would have done pre-operatively. And baseline investigations for pre-operative workout would be my complete blood count, renal function test, liver function test, and stimulated ECG, X-ray.
If the hemoglobin is 6,
yes.
So would you like to do colonoscopy or any other?
I would need to transfuse the patient to an minimum standard for a colonoscopic procedure, sir.
What is that standard hemoglobin?
We usually have around more than 7 grams per deciliter of
8. Okay, fine. So why do you need to have a chest X-ray?
To mainly for ruling out metastasis and for anesthetic for fitness for surgery, sir.
Okay. And what investigations have been done in this patient?
For this patient, the blood count, he had anemia, sir. He had 7 grams per deciliter of hemoglobin, and the ultrasound showed irregular asymmetrical thickening, as sir has mentioned. There was thickening in the lumen, in the cecum for 9 centimeter, and extending into terminal ileum, sir. And we did cast embryonic antigen, and it showed 188 nanogram per ml. And contrast enhanced CT abdomen and pelvis was done, and showed a heterogeneous enhancing thickening in the ileocecal junction and distal ileum, cecum, and appendix, with a maximum thickness of 2.5 centimeters single wall thickness.
What else you are seeing in this picture? You can see here. See here, apart from the thickening of the bowel, it looks like a peritoneum is involved here. So that's why probably on examination you felt it's tender mass. I'm not very sure, but my guess is that probably, yeah, above, little above. Okay, yeah. Okay, proceed.
And this was the CT report that was obtained, sir.
How do you explain, if you're suspecting malignancy, thickening of the distal eye?
Yeah.
Could be an ulcerative type of growth, ulcer proliferative type of growth.
It has to be from the colon, no?
Yes.
I'm asking, see, they have written circumferential thickening of the ileum. It's not even an extrinsic infiltration from a surrounding malignancy of the colon. That can happen, that can invade anywhere. But when you have a circumferential thickening, that means it is that organ also has the lesion.
Yes, sir.
And it doesn't appear to be an extension of a lesion from some other organ. So how will you explain that? If you have a finding like this, what will it suggest? That the ileum is thickened, this thing is thickened, the colon is thickened.
There could be luminal vertical spread of the tumor that can happen.
Why you're not, how you're ruling ileocecal tuberculosis here?
It is a possibility. Yes.
Because that is what is pathognomonic about ileocecal hyperplastic tuberculosis. It involves the ileum and the cecum.
Yes.
And in addition, you may find lymph nodes in the mesentery also.
Yes.
Okay. Fine. Again, I'll ask again, is there a role for a PET CT? I'm sorry to ask Vikram, because
no, not at all. Absolutely.
CA levels are very high.
Yes.
Very high, definitely.
It's definitely 188.
Yes.
So probably a small group of patients, there is a role for PET CT. I'm not saying it should be done. It's not a mandatory. But when the CA levels are very high, we tend to do a PET CT just rule out lesions in other parts of the body. Okay. Fine. So you open the abdomen, and again, I'll ask same question. There's a lesion in the liver. What will you do? Single lesion in the liver.
There is two schools of thought. Initially, some people think we can address the primary and the liver lesion together, but some people prefer to address the primary first and liver on second sitting, sir. I would go if there is single lesion in the liver, there could be metastatectomy could be done, sir. There's a single small lesion in the liver.
It all depends upon the condition of the patient. Where he's on a 59-year guy, 59-year-old. So we need to know his 52. Like to know his general condition, cardiac status, those things.
I would like to interrupt here. Dr. Karthikeyan, you should have asked the single lesion detected on what? Whether it was detected intraoperatively, a finding, or whether it was detected on imaging. Why you would like to ask this question? Especially intraoperative, you open the abdomen, you'll find there is a metastasis there in the liver, single.
There could be some incidental finding that was not malignancy.
No, not incidental finding. The thing is that if you find one lesion does not always mean one. So what further you'd like to do to know that it is not one and it can be more than one? You said you'll do resection of that lesion before that.
We do not usually do biopsy of liver lesions, sir.
No, that's not my question. Any further investigation you'd like to do to find out the liver has got more than one lesion, or it's only a single isolated lesion? Can you do any type of ultrasound?
Intraoperative ultrasound, sir.
Intraoperative ultrasound, is it not? It will be giving you additional information, and if it confirms a single lesion, then you should go ahead. In the exam, you should be very careful in answering the questions. You should not jump and straight away answer it. Okay.
Suppose if there are 2-3 lesions, you have done intraoperative ultrasound and found one lesion in the right lobe, 2-3 lesions in the left lobe after opening the abdomen. So what would you do?
Sir, I would dissect the primary and come outside, sir, and
Why it's in a disease, M1 disease, it has spread to the liver.
but even then,
You are correct. Your answer is correct. You would resect definitely. But the reason behind your decision?
sir, on giving chemotherapy, adjuvant chemotherapy,
That's different. This patient is bleeding. His hemoglobin is 7. He continued to bleed if you do not resect. So even if you find a liver lesions there, so whatever you do is in a palliative therapy, palliative surgery to stop the bleed. No, you need to resect it. Okay. And then go for a chemotherapy. Any questions?
I was just wanting to ask one hypothetical question. Like, suppose this patient came with tenderness and a vague lump over there and multiple episodes of bleeding. Not really a lump. What would be your diagnosis be?
not a lump, just only bleeding.
Bleeding and lumpish feel, but multiple episodes of bleeding, pretty exhaustive bleeding. What would be your diagnosis? Because we've already talked a lot about colorectal, so I was just a little off.
Diverticulitis is a possibility.
Which one?
Diverticulitis is a possibility. Tenderness and bleeding in this age.
No, just a lot of bleeding, then it stops, then again this thing, it just kind of goes in a cycle. You said multiple episodes of bleeding, right? And pretty large amounts of bleeding. What would be the it's
erosive lesions. Erosive lesions could be, but Meckel's diverticulum with gastric lesion.
Yeah, okay, no, but colonic. I'm talking about the right-sided colon. And we've had to go in and sometimes blindly in the past do a hemicall for, because we couldn't find. Now there is a diagnosis name and better methods of identifying it.
Colitis with bleeding also.
No, I was asking about angiodysplasia. Anyway, so that is one different. I think, yeah, continue with whatever. I think that was just an offshoot.
Usually, have you heard of something called total mesocolic resection?
Yes, sir.
What do you mean by that?
Excising the mesocolon of the right side, including all the 4 levels of lymph nodes up till the vascular origin, sir. All the 4 levels, including epicolic, pericolic, intermediate, and principal lymph nodes.
How do you identify? What is the plane of resection?
At the origin of the 3 vessels, sir. Ileocolic, ileocolic, and right colic.
Okay. You can read about it. Okay, it's on minimal access surgery, you can see clearly the differentiating fat color. Okay, that will tell you retroperitoneal fat and the mesocolic fat. That's the plane you go and then do a total mesocolic resection. It's an extended version of TME, is it not? So the concept has come from there, where you do a total mesorectal resection. Similarly, you do total mesocolic resection. What is the principal difference between open surgery and minimal access surgery for right colon resection? No, have you seen any operation open minimal access?
In open surgery.
One you will know the primary difference. One of each.
I've seen open surgery of the right hemicolectomy, but minimal access I have not.
It's there on YouTube. You can see that. You have to see in the hospital itself. It's from one, open is always lateral, lateral to medial approach, whereas minimal access is from the medial to lateral approach.
Yes.
What organs you would like to particularly see and preserve when you do this surgery? Right radical hemicolectomy. Organs and structures.
The structures on the behind posterior aspect of the colon and cecum should be preserved, sir. Namely, the ureter on the cecal region and right kidney and duodenum on the right side, sir.
It's not the kidney, but you have to particularly look for the gonadal vessels, you have to look for the ureters, and you have to look for the second and third part of the duodenum.
Yes.
Okay, so when you have this gonadal vessels and ureters, if you don't breach a fascia, usually they still well protected. If you don't breach a fascia, it'll remain well protected. Which fascia I'm talking of? Which is there between the ureters and the colon, mesocolon.
Tracing from the white line of Toll, sir.
No, the fascia was described by Toll, but it's not white line of Toll. White line of Toll is on the lateral aspect of the colon. It's called fascia of Toll. Yes. So that is, if you don't breach it, then the safety of these structures is improvised.
What are the vessels ligate in a right hemicolectomy?
The ileocolic artery, ileocolic vessels, right colic vessels, and right branch of metalcolic vessels.
What is extended right hemicolectomy?
Extended right hemicolectomy is usually done for proximal transverse colon growth, which includes ligation of the entire metalcolic artery and removal of the transverse colon up to the splenic flexure. Before that's proximal to the splenic flexure.
Dr. Shinoy is there with us. Dr. Shinoy, you'd like to ask something?
Good evening, sir. Good evening.
Good evening. Good evening.
I'm listening. Actually, he's doing extremely well. Actually, I'm happy for the candidate.
No doubt.
So one or two questions from my side. Just small comments. Firstly, you can be very firmly say that it is instead of right side, you can say carcinoma cecum. I think nothing wrong. All of us will accept the diagnosis. If you say carcinoma cecum, especially you said it is in the right iliac fossa. That is the one thing. Only if they ask you the differential diagnosis, you can always tell tuberculosis because it's a 18 months duration, no?
Yes,
18 months, pretty long, but even though no features are really suggestive, no. So, but if they ask you,
yes.
I just want to ask the panel here, sir, whether if they ask you further any other tumors which can give rise to this situation of a bleeding, intermittent bleeding, nodular mass. What about the stromal tumor, sir? If they ask you, 1.5 years duration, large ones.
Stromal tumors do occur, but it's circumferential thickening. So that's unlikely. They're all exophytic lesions.
Clinical, no, sir. Clinically.
I consider carcinoma and lymphoma.
Lymphoma. I was about to ask if at all a bowel pathology, if you are giving, another possibility is that. That is one. Second thing, as rightly told by Dr. Birappa, the tenderness, if you see carefully, it is infiltrating the abdominal wall. So I just wanted to add one more thing here. We generally say that no, the colon is chemosensitive and rectum is radiosensitive, not that other way also. But so you may have to take out the portion of the peritoneum or even abdominal wall, few muscles, and whether the role for a radiotherapy in this patient, particular patient, if the abdominal wall is infiltrated. And one or two other question is how to identify ureter. I think you should be able to tell me that on table.
On table, the ureter, clinically by myself on table, I would detect ureter by its location, sir.
Location, yes, one.
The
Yes.
peristalsis of the ureter on women, and the color of the ureter, the pale color of the ureter. And if needed, I can get the aid of a urologist and place a DJ stent if I'm not confident.
That I think, okay, that will, you have done the CT scan. I think it is very clear that hydronephrosis or any other pressure effects are not there. So probably it is you would have done if there is affected preoperative rather than, so that I don't think you'll have difficulty in identifying this. So tenderness was the question which was asked to you. So that rapidly growing parietal mass. Another thing is it is, you said appendicitis sometimes, but I was thinking whether you can also give a intersusception. The right-sided cecal malignancies are also known for intersusception. Veerappa, that's all from my side. Thank you. Thank you, sir. Thank you, sir.
Yeah. Regarding the ureter, I wanted to ask you one question. Okay, you have not answered the most important answer. How do you identify the ureter on the table in open surgery? Most important landmark. You look for that. What you told, how the ureter will look and how do you differentiate from the vessels. But first you have to find it. Where do you find it exactly? It lies particularly on one point almost always. What is it? That is where we look for it.
Apex of the sigmoid mesocolon is a landmark.
See, you are really talking of right side malignancy.
Right side, no? Right side. So
end of the mesentery.
It lies on the bifurcation of the common iliac.
Common iliac.
Always. External iliac and internal iliac, exactly where it bifurcates, the ureter will cross there. If you do not find the ureter there, you should find it on the reflected peritoneum, which lies just above that. You will find the ureter in these two places.
Yes.
That is the way to identify the ureter on table.
Yes.
Yeah.
So then you look for the other things. Yeah, please go ahead. Yeah.
If you're are you done? Can I ask another question?
Please.
Yeah. So he's done well, and he's had the advantage, of course, of having another lady before him. But could you tell us a little bit about Lynch syndrome and Turcot syndromes?
Lynch syndrome is hereditary non-polyposis colorectal cancer. It usually includes malignancies of the colon, rectum, and other GI malignancies, including the pancreas and endocrine tumors and ovarian tumors. And criteria for classifying a patient as with Lynch syndrome is based on the Amsterdam criteria too. Based on that, if we detect a patient with Lynch syndrome, we'll have to screen them manually in every 5 years because they are at high risk for developing colorectal malignancy. And the Amsterdam criteria includes three people in the family with.
So whatever. So the ASCO guidelines now say that all patients of colorectal cancer should be screened for, all young patients should be screened for Lynch syndrome. Okay, that's like a standard of this thing. What is Turcot?
Turcot syndrome is familial adenomatous polyposis in association with brain tumors, medulloblastoma, or other cerebral tumors.
I think one of our examiners were asking about skin patches. He asked them 3-4 times, black patches, keratocanthosis, I think for the last this thing. So yeah, so that is one of the things that you could see in Lynch, right?
Yes.
Yeah, I think you're well read. Yeah, good presentation.
Thank you. Thank you.
Karthikeyan?
Yes.
So when Veerappa sir was discussing, you told something about adjuvant chemotherapy, I think. What I want to know what you are about to say.
Sir, usually for stage 3 diseases or any distal mets, as said, stage 4 will need adjuvant chemotherapy, sir.
I object. See, what is adjuvant? See, when there is a distant metastasis, can you use the word adjuvant?
Palliative chemotherapy.
Yes, keep it in your mind. When you say adjuvant, it has to follow the primary treatment. That is, it deals with the microscopic residual disease. Adjuvant deals with the microscopic, whereas palliative is for a distant metastasis. Am I right?
Yes, sir. Absolutely.
Day 5 post-surgery, you find bile in the brain. What do you suspect?
Based on the when I find the bile in the drain, I would.
I said day 4, day 5.
There is a possibility of anastomotic leak or any missed perforation as well, sir.
Golden yellow. Golden yellow bile. Can suspect diurnal injury?
Yes. Because
could be diurnal injury.
yes.
How do you manage?
Sir,
If there is
I
an
will
injury.
watch for the drain, sir. If it's controlled drain fistula, we could manage conservatively, sir, and watch the drain and the condition of the patient. If it warrants, if the patient is deteriorating, we will need to operate on the patient, sir. Based on the condition.
Today, if we see a bile in the right drain and the suspect an diurnal injury, so what is the line of management? If the bile is say 100 ml continuously for more than a week and you are not able to give orally because it's leaking there.
You need
One
to.
principle what you said is correct. You'll observe initial definitely, whether it's collecting the rest of the abdomen or not. That's correct. Anything else?
I'll do a diagnostic laparoscopy to check if there is
How
actually.
do you confirm that?
Sir?
How do you confirm that?
Check the biochemical analysis of the drain before going in for surgery.
Any contrast study? How do you confirm that there's an
Oral contrast could be given. Oral contrast study could be done, and if there's any contrast extravasation, is present.
Again, the principles of controlled fistula, uncontrolled, you may have to go in and then repair and do a feeding anastomy, something like that. Controlled fistula, you may observe.
Yes. Okay.
Any more questions?
Yeah, one question, Karthikeyan, since you are done well, since the discussion of young people had come. In the pathology, anything specific you would like to ask in this type of patients in carcinoma cholerae? Pathology. Pathology means report. Say final report will come. Say adenocarcinoma. What are the other things which you expect?
I will ask for nodal status, sir. How many nodes are present? How many are there?
Yeah. What is the recommendation? Like
at least 12 nodes should be present in the post-operative specimen.
Usually they report.
How many?
At least 12 nodes should be present in the post-operative specimen, sir. And besides that, I'll ask for any lymphovascular invasion if there's any present. Grade of the tumor, if there is high grade or low grade tumors, and differentiation, if there's any mucinous variant or colloid variant.
What I just wanted one or two things because you are done well. What is MSI stands for?
Microsatellite instability.
One is that, especially in the younger patient. What about signet ring carcinoma, which has got good prognosis?
Signet ring has poor prognosis.
So look for hello. Yes, look for signet ring carcinoma, aneuploidy, mitotic figures. All these will also becomes an indication for chemotherapy, even in the some disturbance, in absence of even if the lymph nodes are negative.
Why do you want to know the number of lymph nodes, vascular, perivascular, or perineural invasion? Why do you want to know all those things?
To plan for chemotherapy or other modalities of treatment, as well as the prognosis for the patient and plan of screening.
Yeah.
If it comes down to tuberculosis, what will you do? Prognostic biopsy is suggestive of tuberculosis.
So since this patient has anemia and but not any obstructive features, he might not warrant surgery if he had tuberculosis. So I would start him.
You have done a right hemicolectomy and biopsies.
No, initially I was asking colonoscopic biopsy, so that's why he's responding to that.
Okay.
So you'll not do surgery and put the patient on ATT. Post ATT, the patient goes for obstruction because of the fibrosis that develops. Then what will you do?
Sir, post-surgery and ATT, sir?
No, it's a colonoscopic diagnosis. Then the patient is started on ATT. You said you'll not operate, is it? And you have started the patient on ATT. Now, while the patient is on ATT, few months, patient goes for obstruction, subacute, which is becoming more and more troublesome for the patient. What will you do?
If he is presenting with obstruction, I will have to do surgery and
what surgery?
Limited resection of the involved part of the colon, sir.
What is the operation called?
Limited resection of the.
Limited. Why it's called limited?
Sir, only the ileocecal region that is involved we remove, but not the whole entire colon or blood supply or lymph nodes need not be removed, sir. So only the ileum and cecum region is removed and ilioascending can be done.
You have done the surgery for the patient. Patient post-operatively develops hypotension. You feel that bleeding is there. You do a post-op ultrasound, bedside ultrasound. No correction is there. And you're given fluids, you're given even blood, but the hypotension is not responding. What will you do?
Sir, if
in this patient, I'm asking, where you have done surgery for a limited resection.
There could be some luminal bleeding that happens. And
for the patient to have intractable bleeding, the patient has to have significant amount of bleeding. That's not there.
You need to think a little out of the box. Think a little out of the box. Everything doesn't have to be at the intestine, no? He's trying to ask you an overview.
A retroperitoneal bleed could be not visualized on ultrasound.
Retroperitoneal bleed?
No. Something else in the retroperitoneum.
Sympathetic injury, nerve injury could be. Because
okay, I will give you a hint. You have given one drug. Okay, one smart resident is there. That person has identified the problem, has given the drug. The patient's blood pressure subsides. What the patient has received?
I think we're giving him too many clues.
No blood is given. Nothing is there. Okay, I'll give you the answer. Steroids were given, and it is blood pressure stabilized. So, what was the problem with the patient?
Sir, the patient went into adrenal crisis.
Due to?
Adrenal gland injury, sir, in surgery.
Adrenal gland will not get injured, man. Radical colectomy. Why it should get injured?
Sympathetic nervous system.
No, it's due to concomitant involvement of the adrenals by tuberculosis. Okay, so whenever a patient has abdominal tuberculosis, you have to operate on the patients. You have to keep this in mind so that sometimes patient goes into Addisonian crisis.
Yes.
Okay,
yes,
that's the question I was highlighting.
Yes.
No questions further from me or done well? Anybody else?
Did well, Karthikeya.
Thank you, sir.
But hardly any students. We are the 6 examiners or 7 examiners and 10 students.
No, they have Facebook also, so some could be on.
Okay, they will not be knowing.
Yeah, they will not be allowing everybody on this platform.
Okay.
So,
then it's okay.
So
Yeah,
generally,
quite well.
Yes. Thank you.
Can
Shana,
we
you're
end?
saying something. Shana, you're saying something. Rajgopal.
no, what I was telling is generally live like this, the number will be less, but those who are a bit serious, they will be watching it whenever they have free time, sir. Maybe
recorded version.
They usually maybe after 12 o'clock, 1 o'clock, maybe tomorrow, day after, whenever. So usually.
Madam, there's one question for you. Roll-up vaccine in colonic cancer.
Oh, you're asking me?
Madam, yeah, there is a chat box. There is a question put up for you.
So there are a couple of this is the, I think, commit trial which was there, And so there are vaccines where they put single tumor cells along with BCG, like they do in the bladder. So they're trying it for colorectal, or they grow tumor cell cultures and then they give an adjuvant this thing. So, so they've been using it in the COMET trial and it's been working very, very well. So, and some of the vaccines are tagged along with the immunomodulators, so the CKIs. So there's been a lot of promising work that's coming out from those trials. So I think for the exam point of view, they should be aware of these vaccines. So that's the reason I brought it up.
Thank you.
If nothing further is there, I think we can close the discussion. Dr. Kanagvel, thank you very much for the opportunity. On behalf of everybody, I'd like to thank you.
Yeah.
And
Thank you, sir.
Thank you, sir. Thank you, all faculty.
Thank you, sir. Thank you.
yeah, I think Dr. Kanagvel, are you there so that we can close?
I think he's not there.
I think probably he might be busy.
Yeah, good
So I
night.
think, yeah,
And,
okay, all good
Good
night.
night.
And thank you.
Good night.
Thank you
Thank you,
very
sir.
much.
Thank you, sir.
Thank you, sir.
Thank you. Thanks, bye bye.